Hi, welcome to tonight's VCU Health Virtual Seminar on Breast Health. My name is Donna Wilson, and I'm a breast nurse navigator at VCU Massey Cancer Center. Tonight, we will discuss our multidisciplinary breast health team combines their insights to diagnose patients, recommend treatment plans, and coordinate care. We have a great group of speakers tonight. I'm proud to work with all of these physicians. First is Dr. Priti Shah. She is the Director of Breast Imaging at VCU Health and Assistant Professor in the Department of Radiology at the VCU School of Medicine. Next, we have Dr. Candace McGuire. She is the Chief of Breast Surgery, Surgical Leader of the Breast Cancer Collaborative Care Clinic, and member of the Developmental Therapeutics Research Program at Massey. She is also a professor in the Division of Surgical Oncology at the VCU School of Medicine. Dr. Mary Helen Hackney is a hematologist oncologist at Massey. She is also the Director of Quality Control and Safety and Associate Professor in the Division of Hematology, Oncology, and Palliative Care at the VCU School of Medicine. Dr. Doug Arthur is the Chair of the Department of Radiation Oncology, Associate Director of Clinical Affairs, Florence and Hyman Myers Endowed Chair in Radiation Oncology, and a member of the Developmental Therapeutics Research Program at Massey. He is also a professor in the Department of Radiation Oncology at the VCU School of Medicine. Dr. Lauren Nigro is a plastic and reconstructive surgeon at VCU Health and assistant professor in the Department of Surgery at the VCU School of Medicine. Welcome. We'll have questions and answers at the end of our presentation. So before we begin, I would like to first make note, we're going to hold all the questions to the end. Please feel free to drop any questions in the comments and we'll address them at the end in our Q&A session. See, I am a breast nurse navigator and I work with our breast cancer collaborative care clinic, which is where our patients come and they're able to meet our providers. They will meet a breast surgeon, medical oncologist, radiation oncologist, and a social worker. We have this every week on Wednesdays and we'll be rolling it out downtown on Tuesdays. You also can download our free guides to get tips for better mammogram experience. You know the importance of having regular breast health screening, but let's be honest. No one looks forward to having a mammogram. This guide contains half a dozen helpful suggestions to prepare you for your mammogram and make your screening experience as pleasant and comfortable as possible. In addition, Massey has a free guide on breast cancer support that goes beyond our complete guide to treatment, recovery, and reconstruction and support. If you'd like to learn more about Massey's breast cancer care, we invite you to complete this form to receive our comprehensive digital guide on how we'll care for you and support you. All right. Do we have our screens up? Oh, there they are. So download that guide. We'll now open, and we're going to have Dr. Priti Shah start off our program.
Thank you, Donna. Good evening to everyone. Thank you so much to Massey Cancer Center for having me on this panel and to our audience for joining us tonight. As a radiologist, I interpret mammograms and breast MRIs. I do breast ultrasounds and perform biopsies and other procedures needed to diagnose and help treat breast cancer. Next slide, please. So I'm a doctor that most women will never meet, but for those 1 in 8 women who do get breast cancer, if it's found by imaging, it's found by the radiologist. Next slide, please. Since I'm a radiologist, I'm a very visual person, so I thought, what better way to introduce a patient's journey with breast cancer and our collaborative team approach than with a screening mammogram? This is the left screening mammogram of a 41-year-old woman with no family history of breast cancer. Now, for those of you who've had a mammogram before, you'll recall how the technologist positions your breast. On the left is that top to bottom view, and on the right is the side to side view. This patient also lets me illustrate a hot topic in mammography. This woman has dense breast tissue. Dense tissue is normal for over 40% of women. It's just how their tissue is made, and it's determined mostly by hormones and genetics. It refers to having more of the white tissue than the gray tissue, and so it's harder to see through. The grayer tissue is fatty, and the whiter tissue is a combination of the milk glands and fibrous tissue, which kind of holds everything together. The main problems with dense breast tissue is that it can increase the risk for breast cancer, and small lumps, be they cancers or non-cancers, they can hide because they're the same shade of white as normal dense breast tissue. So finding a small cancer can be kind of like, next slide please, hunting for a polar bear in a snowstorm. Next slide please. But if we take a closer look at this patient, we see some bright white dots on the mammogram circled in yellow. And even on a background of dense white breast tissue, these dots stand out as even brighter. These are calcifications or calcium deposits. Now, most calcium deposits in a woman's breast are benign. They're not cancerous and they come from fibrocystic and hormonal changes. Next slide, please. But in this patient, we zoom in even further to see that these line up. The radiologist called this patient back from her screening mammogram, and this is a magnified view from her diagnostic mammogram. Knowing this patient's diagnosis, I can tell you that these are lined up in a milk duct, and these are the earliest sign of her breast cancer. The calcium deposits form among cancer cells, but everything is confined to the milk duct since at this point, the cancer hasn't yet broken through the milk duct to form a lump that's feelable on a breast exam. Next slide, please. This is just a cartoon showing our milk ducts. They're like tubes that run through the breast. And you can imagine if you have calcium dots lined up in a duct, they would form a line on the x-ray as well. Now, mammograms are not perfect tests, but there really isn't a perfect test in medicine. The reason that mammograms work so effectively at saving the most lives, at decreasing deaths from breast cancer by more than 40%, is because it's the best test for most women at detecting small lumps, and more so, these tiny calcium deposits amid cancer cells before there even is a lump, before it has a chance to spread to lymph nodes or other organs. This right here is the earliest stage 0 cancer, and it can be diagnosed even despite extremely dense breast tissue. Ultrasounds and CT scans, they can't do that. And even though 3D mammograms can sometimes help us see lumps better in dense breast tissue, you don't need a mammogram to see calcium deposits. You don't need a 3D mammogram to see calcium deposits. These images that I've been showing are all from 2D mammograms. Next slide, please. Now, I'll defer to my colleagues to discuss all the treatment options, but I just want to share with you a few more examples of the radiology of breast cancer to segue to the rest of the panel and illustrate that there is hope even for treatment. There is hope for treatment even if cancer isn't caught at stage 0. This patient has a more advanced cancer. This is a mammogram of the right breast, and the patient had a lump that she could feel at the top of the image. The image is there, circled in yellow, and it was about the size of a quarter. She also had metastatic lymph nodes in her armpit, pointed out by the arrow in the corner of the image on the right, that the radiologist diagnosed by needle biopsies back in January. We could see her breast lump on the ultrasound image below. It kind of looks like a marble, and on the mammogram, it stands out because it is surrounded by that gray fatty tissue. It's not camouflaged by the dense white tissue as in the last patient. Next slide, please. After several months of chemotherapy, all the lumps disappeared, as we see on her follow-up mammogram. There's a teeny tiny ribbon-shaped thing in the top corner of the film that's circled in place of the lump. That is a metal clip that the radiologist places before treatment to mark the cancer, so if it does vanish, we'll know where it was to do the surgery. This patient was able to go on and have a lumpectomy. Now, because the lump was no longer feelable or palpable, the radiologist marked or localized the site of her cancer in the breast and in the lymph nodes using X-ray and ultrasound before her lumpectomy, so the surgeon knew where to go. Now, at VCU, we most commonly place a magnetic seed for the surgeon under ultrasound or mammogram. Next slide, please. This is a different patient with a similar story who had an MRI before chemotherapy and after. We see her cancer lighting up as a white ball in the middle of her breast. This was also about the size of a quarter. After chemotherapy, the image on the right shows that the lump is gone. Next slide, please. This last patient had a similar, bigger lump at the time of her diagnosis in 2012. It was a little smaller than the size of a ping pong ball, and that's circled in the top of the images of the left breast. On the ultrasound, we can see it standing out kind of like another dark marble. Next slide, please. She also had chemotherapy, surgery, radiation, and she's disease-free 8 years later, as we saw on her most recent screening mammogram just about a week ago. The lump is gone. Those bright white lines, they're not calcifications, those are just some surgical clips from her operation. So while most women will fortunately not ever meet their radiologists, through a variety of tests like ultrasound and MRI, in addition to mammograms, we play a role in finding, diagnosing, and following cancers, and of course, non-cancerous conditions too, helping the surgeons and oncologists behind the scenes. If we diagnose a breast cancer, we schedule the patient for consultations with this awesome care team sharing the panel with me for the rest of this patient's journey. And I should mention that even if a patient didn't have their imaging workup here at VCU, but are at Massey Cancer Center for treatment, our radiologists re-review all outside imaging and present it to the treatment team at a weekly roundtable discussion. So let me turn it back over to them for an overview of how cancers can be treated once they're found. Thank you.
Thanks, Dr. Shaw. As the surgical oncologist of the team, I'm going to go through a little bit of surgical options for breast cancer. So when somebody comes to me as part of the multidisciplinary team, we've got a lot to think about. So we need to think about mastectomy versus breast conservation surgery or lumpectomy, as Dr. Shaw discussed. Patients often ask about contralateral prophylactic mastectomy. And we also wonder what we're going to do with those lymph nodes. We've seen those lymph nodes look enlarged. We've seen them look normal. What do we do with them based upon those different scenarios? And whether if a patient is going to have a mastectomy, whether or not they're going to choose or be eligible for reconstruction. Next slide. So when we talk about breast conservation, second option that I mentioned, that essentially is lumpectomy plus or minus radiation. And in most women, as Dr. Arthur will discuss, radiation is really an essential part of treatment after a lumpectomy. In any woman under the age of 70, we're going to recommend it very strongly after a lumpectomy. And you can see in this diagram what a lumpectomy might look like. Really what we're doing is we're taking out the tumor and a rim of normal tissue around it. The great thing about a lumpectomy is that it's a same-day surgery. You're going to go home that afternoon. There are no drains involved. There are stitches underneath the skin. It's incredibly low maintenance. There is some recovery time involved, obviously, but it's a much lower amount of recovery than you're going to see with a mastectomy. And so women tend to choose this more often when it's an option. We've already discussed why it might not be an option. And so oftentimes in order to achieve a lumpectomy, women with larger tumors will have neoadjuvant or preoperative chemotherapy or preoperative what we call endocrine therapy, which Dr. Hackney will discuss. And so these are some options to get somebody from a surgery they don't want, like a mastectomy, to a surgery that they do want, like a lumpectomy. Now, there are slight differences between lumpectomy and mastectomy. Lumpectomy does have a slightly higher risk of local recurrence than mastectomy. And what I mean by that is that it's a little bit more likely, we're talking single-digit percentages, that a tumor will come back in the breast over time. However, whether a woman chooses a lumpectomy or mastectomy, their outcome in terms of being here, overall survival, being here for many, many years cancer-free is exactly the same. And so that's why we consider these equivalent options. There are options also to achieve a lumpectomy when you have a little bit of a bigger tumor and a woman doesn't want a mastectomy and is not a great candidate for neoadjuvant chemotherapy. And that's when I might team up with somebody like Dr. Nigro to look at some oncoplastic surgery. And that's when either me, myself, or Dr. Nigro, after I've removed the cancer, are rearranging the breast so that we're filling that defect and allowing that patient to have an excellent contour to the breast, to the point where the breast is actually looking the same or better than it did prior to surgery. Next slide, please. Now, this is a pretty traditional picture of a mastectomy, what we would call a modified radical mastectomy, which is a scary term. Really what that means is removing all the breast tissue, all of the skin overlying it, and all of the lymph nodes underneath the arm on that side. This is very rarely performed these days. Most women who have a mastectomy, at least in our practice, will opt for at least a visit with their plastic surgeon to talk about options for reconstruction. And we find that many of our patients have reconstruction, so that when they wake up, they will have something that resembles their normal breast when they begin. Reconstruction is a process, and Dr. Nigro will discuss that. Women who need a mastectomy versus a lumpectomy. We always wonder who needs a mastectomy. So women who have multiple tumors in multiple different parts of the breast, no matter how much chemotherapy we give that woman, those tumors are never going to grow together, and that woman's going to be best served by a mastectomy. Women who have that stage 0 cancer, DCIS, that's all over the breast, there's nothing that's going to shrink that down, and oftentimes those women are best served by mastectomy. There are also women who have genetic predispositions to cancer, the BRCA genes, or what I like to call the Angelina Jolie genes. Those women really do enjoy a benefit to not only mastectomy, but what I mentioned before, which is contralateral prophylactic mastectomy. So oftentimes we see when a woman chooses a mastectomy on one side, they really consider what to do with their opposite breast, more so than when they have a lumpectomy. And so some of the positives to a contralateral prophylactic mastectomy or a bilateral mastectomy are that everything's symmetrical. They all look the same. You're not going to have to visit Dr. Shaw anymore. You're not going to need mammograms in most cases. The risk of cancer in the opposite breast is lower. However, the major downsides are that you double your risk of surgical complications. You double the risk of chronic pain. And you do not increase your overall survival. So unless you have one of those gene mutations, you're not going to stay on this earth one day longer because of removing your opposite breast. So it's a lot of surgery for a little gain for a lot of women. However, when I lay out those options for women, a lot of women choose it, and we see that still today. And that may be because we have amazing plastic surgeons and the opportunity to give people an excellent cosmetic outcome. Next slide, please. And when I say excellent cosmetic outcomes, I'm talking about whether we're using a skin-sparing or nipple-sparing mastectomy. And so we have actually, in recent years, moved more and more towards trying to keep all of the skin of the breast, including the nipple. And that you can see here in that first slide, the nipple-sparing incision underneath the breast. Oftentimes, we don't want to keep the nipple. We can't because the cancer is too close to it. Blood supply is poor, or it's in a bad position. And so we will remove the nipple and reconstruct one. So those are our two options when we're looking at doing immediate reconstruction. Next slide, please. The last thing I want to talk about is axillary surgery. So every woman who has an invasive cancer really needs to have their sentinel lymph nodes checked to make sure that cancer has not spread to their lymph nodes, which then tells us a little bit about what the likelihood is that it will come back, how aggressively we need to treat it, and what the likelihood is there's cancer elsewhere in the body. And when I say the sentinel lymph nodes, you can see here what I'm talking about. So what we used to do is what we did in that picture that I showed you a couple of slides ago. So we used to just remove all of the lymph nodes underneath the armpit, which was great, but it led in about 30% of women to lymphedema, which you can see on the right there. And so it can be very mild, it can be very severe. We don't know how to predict who's going to get it, but the best thing we can do is to prevent it. And the way that we do that in most women who are clinically node negative, meaning we don't think they have any cancer in their lymph nodes before surgery, we will actually inject a couple of dyes into the breast, and those travel up to the lymph nodes underneath the armpit or the axilla. And we will remove just 1 or 2 lymph nodes underneath the axilla that are just as predictive as all of the other ones. And we reduce their risk of lymphedema down from 30% to about 3 to maybe 5%. So this is an essential tool in our ability to remove cancers, stage cancers, tell people what their prognosis is, and allow some guidance for our medical oncology colleagues to decide how they're going to treat our patients and our radiation oncology colleagues. So with that, I think I'm going to turn it over to Dr. Hackney.
Hello. Thank you so much for allowing me to speak tonight and to be all part of our team. I'm a medical oncologist. So what do I do as a medical oncologist? Well, a couple of the things are listed here. I'm very involved in reducing the risk of breast cancer. So if people have a high-risk lesion, such as atypical ductal hyperplasia, they may talk to me about going on hormonal therapy. If you're a family member of a patient with cancer, you may come to talk about using hormonal therapy as a risk reduction agent. I treat all stages of breast cancer, either with anti-hormonal therapies, chemotherapy, targeted therapies. We also do some end-of-life care because there are about 38,000 deaths a year from breast cancer in the United States. But even better, there's 2.5 million cancer survivors, breast cancer survivors in the US right now. And all of those women do need care as they continue on living long, full, and healthy lives. Next slide, please. One thing I have to say, because I am at Massey Cancer Center, is that when you meet me, when you meet any of my team members, our team members, you may be asked about clinical trials and clinical studies. And we used to think that clinical trials were only for people who had nothing else left to try. But really, you can use clinical trials anywhere during that cancer journey, from risk reduction to surgery to radiation, anywhere during treatment, and even in survivorship. So I put up a few quick examples here of some of the trials that we're offering at VCU Massey that are important for women with breast cancer. One of the ones we're doing is cardiac MRIs, a clinical trial looking at heart function during chemotherapy and looking at how that heart function and fatigue may affect women long term. We've got a weight management trial. Everybody's talking about their weight. So for women who have stage 2 and stage 3 breast cancer, weight control after treatment is important. So here's a trial looking at how to help women lose weight. Immunotherapy, the buzzword everywhere these days. So an immunotherapy trial prior to starting chemotherapy for certain types of high-risk cancers. There's an immunotherapy trial after chemotherapy, for certain high-risk cancers. So seeing how we can put these new drugs into the standard of care. And all drugs do have some side effects. So we have several trials looking at both neuropathy prevention, that's numbness and tingling in the fingertips and toes, and neuropathy treatment if you get that as a complication of your chemotherapy. So here are trials that can happen anywhere along the way. One of my colleagues and her team are working on survivorship issues, particularly in African American women. So they're doing some work and following people for long term to see what might be some of the challenges they have after a cancer diagnosis and treatment. So you're going to hear about trials and studies, ask about trials and studies. We'll be glad to tell you. Next slide, sorry. Now, in medicine, you'll often hear us talk about pearls, and pearls are little bits of valuable information, and as you string them together, you have a great value. So this whole presentation tonight is a string of pearls. So I want to add a few more to this necklace here. Next slide. So I have 3 slides here, and they're sort of the absolutes of any woman who gets diagnosed with breast cancer. All women who have all people, I want to say people because some men do get breast cancer, all people who get a breast cancer that is what they call estrogen receptor positive, one of the characteristics, estrogen receptor positive cancer should be considered for hormonal-based therapy. It's really anti-hormonal therapy, but in the common language, we call it hormonal therapy. So most breast cancer is estrogen positive, about 2/3 of them. If you're premenopausal, it means your ovaries are still making estrogen. The choice of drugs are tamoxifen, or to shut those ovaries down and use another type of hormonal therapy. If you're postmenopausal, there is a group of drugs called aromatase inhibitors, anastrozole, letrozole, exemestane. These are all available to treat hormone-positive breast cancer in the postmenopausal setting. But if somebody's postmenopausal and they don't tolerate one of these drugs, we can always go back to old-fashioned tamoxifen because that works at all ages. All of these are pills. They're taken anywhere from 5 to 10 years, depending on the situation. And most people tolerate them pretty well and do very well with them. Now, there's still some people with estrogen-positive cancer who might need chemotherapy, but these are always a key backbone of their therapy. There are some other treatments that are available only if you're in the metastatic or recurrent setting. One of those is fulvestrant. And many people will hear about that for recurrent breast cancer. It's in trials to use in the early setting, maybe for somebody who's trying to shrink their cancer before surgery. Dr. McGuire kind of alluded to that earlier. So these are some of the options for a patient with an estrogen positive breast cancer, ask about hormonal-based therapy. Next slide, please. Now, another pearl is if you have what's called an estrogen receptor negative cancer, then those are patients who really need to be considered for chemotherapy. Anybody that has more than a 5-millimeter tumor should talk to a medical oncologist about chemotherapy. It's systemic. It's most often IV medication. It can be given before surgery to shrink the cancer down, sometimes allowing you to have a better surgery, or it can be given after surgery to help improve your survival by reducing the chance of the cancer showing up elsewhere in the body. The recipes, I'm a cook. I always put things in recipes. The recipes for chemotherapy are slightly different depending on the needs. They can be given once every 2 weeks, once every 3 weeks, even weekly, and may last 3 to 6 months. During this time, people are continuing to live their lives while getting chemo. And that's what I really want to emphasize, is not to be afraid. Side effect management is markedly better than it was 20 years ago. And so we have people who are playing golf, playing tennis, working, taking care of families, even while going through breast cancer treatment. Some of the drugs I've listed here, adriamycin, cyclophosphamide, taxanes, carboplatin. Again, there are different recipes for different situations. Your medical oncologist will guide you. We're looking at immunotherapy drugs, and maybe those will be added. We think there may be some new roles for them. So that's science that's ongoing as part of those clinical trials. And there are a lot of drugs that are used if cancer does happen to recur elsewhere in the body. And there's a great diversity of things we can use in that setting. Next slide, please. The area where we've made a huge progress is in cancers that are what they call HER2 positive. This is a particular protein that can occur on about 1 out of 5 breast cancers. All patients who have a cancer that marks out HER2 positive should be considered for the therapy directed against that HER2 protein. The one that everybody hears about is trastuzumab or Herceptin, and it has significantly reduced the risk of distant disease by almost 50%. Been a huge impact in women over the past 10 to 15 years. It's what they call a targeted therapy, a monoclonal antibody. We have another one in the same group called pertuzumab. The two of them together have really made a big difference in women with this type of cancer living without it coming back elsewhere. There are 3 other drugs that are also work against HER2 positive cancers: lapatinib, neratinib, and tucatinib. We take special training just so we can say all these things. But that tucatinib is one of the newest drugs out. It's been out only for about a year. And so you can see things are always changing. These drugs are being used in a variety of settings, more so with people with recurrent disease, but we're using some now in earlier stage disease as well. Similarly, they now have what they call conjugate drugs, trastuzumab with a chemo attached to it. Again, right now in the recurrent disease setting, but being used earlier and earlier. We're finding out how good and how much they can help people prevent their cancer from coming back. So ask, if you have a HER2 positive, what drugs, what chemotherapy, targeted therapy do I need? Next slide, please. Now, where are some things happening? Does everybody get everything? When I first started practice 20 years ago, anybody who had a cancer bigger than a centimeter automatically got chemotherapy. Now we have what we call multi-gene profiles, Oncotype, Mammaprint, PAM50. These take a sample of the tumor, particularly estrogen receptor positive cancers, and they can say, this is a high risk, you should very much get chemotherapy. This is a low risk. All you need to do is really take the anti-hormonal therapy. So this allows us to better tailor what treatment people need. I'm actually giving less chemotherapy now because I have this tool to help people make good decisions. There's also a tool out there now called the Breast Cancer Index, trying to see how long do you keep people on treatment. Traditionally, we kept people on hormonal therapy for 5 years. Now we may keep people on it for 10 years. So again, we're trying to find out ways of better fine-tuning the treatment, for that particular individual. Next slide, please. Genomic testing. Part of that is similar to what we talked about earlier, what I said earlier in the previous slide, with things like oncotypes, looking at particular gene expression. Increasingly, we're using genomic testing, looking for specific mutations or specific abnormalities in the genes of the cancer. A couple of the companies that do this, foundations, Caris, some of it's done at VCU itself, may find mutations that help us pinpoint what's going to be the best drug for that individual patient. An example is a mutation called PDL1. And if that is positive, then there are two new drugs out, pembrolizumab and atezolizumab, that might help patients who have a cancer expressing that. Similarly, a BRCA positive patient might be eligible for olaparib. A PIK3 mutation, alpelisib, I can't hardly say that one. But here are ways that we can look at the cancer and better finesse what the right treatment is. Most of this is being used in the recurrent cancer setting, but again, increasingly we're looking at using it in early stage disease as well. Next slide, please. Now, we don't have a whole lot of time today, and what I've not been able to talk about is when we do genetic testing. We haven't talked about which we only see 5 or 10% of women with a gene abnormality, but it is important for their family. We haven't talked about fertility and sexuality preservation before and after treatment, something that we talk about with all our patients coming in who that may apply to. And we haven't talked about male breast cancer. There's probably only about 1,800, 2,000 men a year with male breast cancer, but they still need to be addressed and they still need to have the appropriate treatment. Next slide, please. And, you know, one of the challenges, as we've talked and we share here, is that they take multiple disciplines to take care of a cancer patient. And I always use this slide for teaching to show all the different people who might be involved. You've already heard from several of us. And so now we're going to go to another one of our team, and that would be radiation oncology, Dr. Douglas Arthur. And he's going to tell you about his role in helping care for a patient with breast cancer. Thank you.
Thank you, Mary Helen. I'm happy to have the opportunity to talk to you a little bit about radiation. But what I'd like you to take away from my short segment is twofold. As you'll see when we talk about radiation, that comes with a number of different choices, especially for early stage disease, that if a patient really wants to optimize their choices and optimize their treatment management, I think it's really critical to be able to see all the subspecialists before you get started, so that an early decision doesn't negatively or alter a later decision that you may have. And that's why we have the collaborative care clinic for breast ongoing here at Massey Cancer Center, to provide that opportunity to be able to meet with everybody early on so that choices can be discussed and you as a patient can participate from the very beginning. So I'm going to walk you through some of the things that I've experienced in my career and the changes that have happened and why it's so important for a radiation oncologist to be able to talk to a breast cancer patient early on so that the choices that they can make can be preserved. The role of radiation in breast cancer shows up whether it's early stage all the way through to its advanced stage, but depending on the patient's needs, their comorbidities, their age, our role may change based on that patient. So if we take early stage disease and we go back to when I was much younger, early stage disease, you really only had two choices. You either went to mastectomy or you went to breast conservation surgery, which removed that lump with the rim of normal tissue as was described by Dr. McGuire. And then we followed with whole breast radiotherapy, delivering one treatment per day, Monday through Friday, break on the weekends for 6 to 7 weeks. Easily tolerated, minimal side effects, very effective in controlling the disease, and also with an excellent cosmetic result. But certainly 6 to 7 weeks of treatment when you're trying to wrap in chemotherapy and other aspects of life can be quite burdensome, but it was very straightforward. And so there really wasn't any reason to sit down with a radiation oncologist early because there was really only one choice. Next. So now, next, when you go to mastectomy, there's a lot of choices in regards to reconstruction. Back in the early days, reconstructive surgery wasn't as sophisticated and there weren't as many options, and the outcomes weren't as great as they are now. And so it's really important that if a patient is considering mastectomy, or really any management, they should speak to a plastic surgeon as well to understand what options there are in that regard. In regards to breast conservation surgery, next, we now have oncoplastic options that sneak in. As Dr. McGuire commented, this helps that lumpectomy surgery yield a better cosmetic result in the end. But the downstream effect of that might impact your radiation delivery, because a lot of times our target is right at the lumpectomy site. And if the tissue gets rearranged, then we are going to have to alter our approach as radiation oncologists, which is fine. We're able to adapt to that, but it's a part of the discussion ahead of time so the surgeon, the plastic surgeon, and the radiation oncologist can coordinate care to make sure we're optimizing your outcome, not only cosmetically, but also in terms of disease control. Next. So then you get into choices of radiation, and you're going to find that over the last 20 to 30 years, they've exploded. When we talk about whole breast radiation, we use various kinds of radiation, photons, which is a pretty standard form using the linear accelerators to deliver that, in combination with electrons, which is a superficial form of radiation. You also have the proton machine, which gets a lot of press because there's a lot of fanciness about it. It can treat breast cancer, but it's something that if you're exploring, you should really understand all options to know whether it's worth the cost and the travel. But we also talk about how we position the patient. Are we going to position them on their back or on their belly? What puts the breast in the best position? What about the dose per day? Are we going to increase the dose per day so we can decrease the number of treatments, otherwise accelerate the treatment? Do we need a boost? Do we not need a boost? And how are we going to approach it with the radiation technique? Are we going to use 3D conformal? Are we going to use this fancy intensity modulated radiotherapy? Tomotherapy is essentially a CT scan that has been converted over to a treatment delivery machine that delivers things in a different way. So there's a lot of different technological options, and they may or may not need to be known ahead of time, but we need to start incorporating those thoughts. Next. And then you get into the world of accelerated partial breast irradiation. In other words, do we really need to treat the whole breast? Because when we do, we end up treating a lot more tissue than perhaps we need to. And then things like lung and heart and so forth, we have to pay attention to. But if we only have to treat part of the breast, maybe we can do it a lot quicker, and we can treat it with a lot less tissue being treated. And therefore, we need to know where the target is, where the surgery was done, where the area of risk of the microscopic residual disease is, so that we can best use a technique to accelerate treatment. And that's why we have to be in touch with the surgeon and potentially the plastic surgeon to really understand where they are so we know where our target is. Do we want to use a brachytherapy approach where we use radioactive sources temporarily, or in some cases, in some parts of the country, permanently within the breast tissue? Are we going to do an external beam partial breast technique to deliver that treatment? We used to be able to treat patients, as I told you before, we were treating 6 to 7 weeks. Now with whole breast radiotherapy, that's rare. It's usually at the most 3 to 4 weeks. There's data talking about treating in as little as a week. And with the brachytherapy, we're now able to treat early stage disease in less than 2 days. So things keep progressing, and the radiation oncologist needs to be available to discuss these different options so that we can be a part of the team from the beginning. Next. The intraoperative approach is something that's been championed for a while in both Italy and the UK, and very rarely in the United States, where all the radiation dose is delivered at the time of surgery. Ideal for the patient. You go in for your surgery, you get everything, you're done, you're gone. The problem is the data is not really bearing out as something that's as effective as we thought it was going to be. And so that's something that is a little bit less dominant as it was, say, 5 to 10 years ago, as the newer publications are showing that it's not quite meeting the mark compared to these other techniques. Next. But we also have to pay attention to maybe not doing radiation at all. And that's where the radiation oncologist can come in early and speak and work collaboratively with the surgeon and often the medical oncologist to optimize treatment. Maybe because of the patient's age, comorbidities, and the availability of hormonal therapy, maybe we don't need radiation at all. And so the patient needs to understand, is that a 5% benefit of giving radiation, or is it a 20% benefit of giving radiation? So they can decide whether it's really worth their time at all. And we're finding that there is a group of women that don't need radiation at all, but we need to be a part of the conversation to be able to carve that out. Next. And lastly, there's actually in the world of non-invasive disease, DCIS, that there's even talk about doing a biopsy only and following those patients. There's some champions across the country. There's a clinical trial open here called the COMET trial here at Massey Cancer Center that's looking at that option. And so we're trying to scale back the role of treatment where we can while preserving cosmesis and preserving disease control. My last statement is in regards to locally advanced disease, where we're dealing with mastectomy and reconstruction. Many of those patients do still require radiation after a mastectomy, certainly not all. And if we don't coordinate our care with the plastic surgeon, then we're not going to idealize the ability to control the disease as well as preserve that cosmetic opportunity with the reconstructive surgery if we don't coordinate our care. So again, from the very beginning, it's important, I think, to get everybody on the same page from the very beginning at diagnosis so that we can move forward smoothly and make sure that the choices are all available to you as a patient. So I'd next like to introduce our next speaker from the Division of Plastic and Reconstructive Surgery, Dr. Nigro.
Thank you, Dr. Arthur, and thank you everybody else for the excellent presentations. My name is Lauren Nigro. I'm an assistant professor in the Division of Plastic and Reconstructive Surgery at VCU. So why consider breast reconstruction? Well, in many ways, reconstruction is the final step in the recovery process from both a surgical and psychological perspective. Numerous studies have actually demonstrated the benefits in quality of life, including psychological outcomes. And that being said, reconstruction is a personal choice. Patients choose to undergo the procedures for different reasons. I would encourage you to have an in-depth discussion with your plastic surgeon to identify your personal goals and priorities. While breast reconstruction may not be the right choice for every woman, it's important that all women are fully aware of their options so they can confidently make their informed choices and manage their expectations. Typically, patients can consider the following pathways for breast reconstruction: no reconstruction at all, use of an external prosthesis, delayed reconstruction, in which the reconstruction is separate from the mastectomy. And this decision can be planned from patient choice, patient's overall health, the decision to address the cancer treatment first, or if radiation therapy is planned and potentially could hurt the reconstruction. And then there's the option for immediate, which is a very popular choice due to the benefits of sharing operative time, having one recovery process, has psychological benefits, and improved appearance and cosmesis. As Dr. McGuire mentioned, reconstruction is a process, and each of these steps can potentially last months. Next slide, please. So how are breasts reconstructed? Well, there are a dizzying array of options available for breast reconstruction, but in general, there are three basic types. Implant-based techniques, as you can see in the picture on top. These are silicone implants, but most typically we use silicone implants for breast reconstruction given their more natural feel and shape. On the bottom picture shows the transfer of tissue from the patient. This is called autologous or tissue-based techniques. And this includes both the tissue rearrangement that Dr. McGuire alluded to, but also moving the tissue from one part of the body to another in a more complicated surgery known as microsurgery. And then rarely a combination of the two can be used. Next slide, please. So with implant-based reconstruction, this is the most commonly performed in the United States. It traditionally is done in a staged manner with the placement of a temporary spacer that we call a tissue expander, as you can see on the picture on the left. And this is done at the time of mastectomy, most typically, where it's placed under the remaining skin and or sometimes under the chest wall muscle. And it can be used in combination with a sling or mesh or matrix made of cadaver skin. And this is followed by a period of expansion in which the expander itself is accessed by an integrated port and filled gradually with fluid, as you can see in the middle picture there, until the patient's adequate goal size is achieved. Usually this can take a few months. And then in tandem, please go back to the previous slide. After those few months, after the appropriate size is achieved, we switch the expander out for the permanent implant. In appropriate patients, I should mention that steps 1 and 2 can actually be skipped, and the permanent implant can be placed at the time of mastectomy, and that is becoming an increasingly common option. Next slide, please. There are several advantages and disadvantages to implant-based reconstruction that should be noted by patients. One certain advantage is that this is a much shorter surgery with a more rapid recovery. There is no donor site, meaning that we are not taking tissue from a part of your abdomen or your thighs, and therefore not creating a separate surgical site. And then this is also the most widely available option, meaning that the vast majority of plastic surgeons can perform this procedure. The disadvantages of this are that it is potentially less natural appearing, as these are foreign bodies, and there can be some element of asymmetry, although we try our best to achieve that. Higher risk for infection is certainly a noted potential with anytime you have a foreign body in your body. And then there's also the risk of forming a scar around the implant itself, which is known as a capsule. The implants with time have the risk of rupturing or opening up and leaking. And then there's also an increased risk of complications in patients who are receiving radiation. And then lastly, there are size limits to implants. The FDA limits how large the implants can be that are currently placed in the United States. Next slide, please. Can you go back to the previous slide? I seem to be missing a slide. Well, let's go to the next slide. With tissue-based reconstruction, this is where you're moving tissue from one part of your body, most typically the abdomen or the belly, and then transferring it to the breast. This has the advantage of replacing like with like, meaning that you are replacing your breast tissue with fatty tissue from your abdomen or belly or your thighs, and therefore it looks more natural. You're also borrowing from an area ideally of excess tissue and removing that. It does have improved long-term outcomes without the need for replacement. As you get older, typically your implants need to be exchanged every 10 years or so. Well, if you use your own tissue, you're not replacing that. And then there's also added benefit for patients that are undergoing radiation, obese patients, and smokers. The disadvantage of this type of surgery is that it is longer, and it does have a longer recovery process. It's more complicated. We are working under a microscope to sew very, very small blood vessels that are about the size of thick spaghetti, and it is not widely available. And then there are, of course, the risk of having an additional surgical site at your belly in particular. There could be healing problems. There could be problems with bulges that form. This isn't common, but it is a risk. And then lastly, there's the risk of the surgery not working, which again is uncommon, but a noteworthy risk to mention. Next slide, please. Next slide, please. And then there are adjunct procedures, meaning there are the finishing touches that we do after we've recreated the breast mound. So there are revisions where we could revise scars, fix the contour or shape of the breast and improve it, and also fat transfer where we can remove fat from some parts of the body and move that up to the breast to soften the appearance of the breast, disguise rippling that may be noticeable with implants. And then lastly, the option for nipple reconstruction. If you do not opt for a nipple reconstruction or a nipple sparing mastectomy like Dr. McGuire talked about, you can have a nipple reconstructed at a later time. And as you notice in the picture on the right, this can be done by tattooing. This is actually the work of Amy Black, who's a local tattoo artist in Richmond, Virginia. And this is actually a three-dimensional appearing tattoo that has a very realistic look to it. This is certainly an option for women who have undergone a skin, not nipple sparing mastectomy. Next slide, please. So what can you expect at your consultation? Well, your plastic surgeon will likely go over your goals, your surgical goals and personal goals. He or she will review your medical and surgical history to assess what options would be best for you. And then he or she will do a breast exam, take measurements, assess any pre-existing asymmetries, which can make achieving symmetry afterwards more of a challenge. We'll also assess the skin quality of the breast envelope or the skin of the breast, the size and shape of the breast. At that time, you can also expect there to be photographs taken to compare pre and post-operative or after surgery outcomes. And then a discussion of the options and recommended course of treatment. Again, keeping in mind this is a joint decision and by no means should be made by your surgeon alone. And then they'll also discuss the anticipated recovery process, the potential risks and complications of each of the different options that you could consider and where you want to go from there. Next slide, please. And thank you very much. Thank you again for all the previous speakers. And I think I'll turn it over to Donna now.
Thank you. I am so proud to be a part of this team and work with these highly skilled, compassionate physicians. We are now going to open up the floor for any questions. We'll read the questions in the comment section along with a few questions that were submitted in advance. I see that VCU Massey Cancer has a one-of-a-kind high-risk breast clinic in Richmond. Who would benefit from a visit to this clinic? I can answer that. A lot of times as a breast nurse navigator, I will get phone calls or emails from patients who are questioning about whether or not they need to be seen by a surgeon or medical oncologist. And sometimes there's no cancer diagnosis. So for a high-risk clinic, you do not have a cancer diagnosis in your body. You may have family members that have been diagnosed with breast cancer, so you're concerned about that. So our high-risk clinic, we will schedule you with one of our nurse practitioners, Patty Bragg, and she'll do a history about you and your family. And if she decides that you need to be followed more closely, she'll go ahead and coordinate that. It may mean that you need MRIs or mammograms. She may coordinate you to see one of our genetic counselors. If we find that you need to be followed more closely, you may meet with medical oncologists like Dr. Hackney. All right. This question is for Dr. Pretty Shaw. If I do have cancer, how likely is a mammogram to actually detect it?
Great question, for which there is not one solid answer. It depends on a lot of things. As we talked about earlier, breast density is one of the major factors that can affect the ability of the mammogram and the radiologist to detect a breast cancer because it can hide small lumps. But it shouldn't have any impact on detecting that stage 0 cancer or DCIS if we can see those calcifications. Patients with extremely dense breast tissue, we know that mammograms are not great at finding small lumps. The overall sensitivity for all patients is about 87%, meaning mammograms may not pick up about 13% of cancers. But 3D mammograms can help find those additional cancers. Some studies show up to a 40% increase in detection with up to a quarter, 25% decrease in callbacks or false alarms. And patients with dense tissue can also get additional tests like ultrasounds and MRIs to enhance cancer detection. But it also depends on the radiologist and their expertise. You know, the national numbers for sensitivity I mentioned is 87%, but that's pooling all patients, all comers. But for example, in our practice last year, our numbers were more around 95%. So it's easy to get caught up in numbers, but the bottom line is that for all comers, for all patients of average risk, the mammogram is still the gold standard. It's the best screening test to detect a cancer. It's undergone a lot of scrutiny over the last several decades and consistently shows a survival benefit of over 40% when done yearly in women over 40.
Thank you. This question is for Dr. Candace McGuire. How common is breast conserving surgeries?
So breast conserving surgery, just to roll back a little bit, is that lumpectomy that I talked about, where we're removing a portion of the breast that's got the tumor in it or the pre-invasive cancer like a DCIS and a rim of normal tissue around it. It's actually the more common of the two surgeries, and we find that nationally, although we've seen variations over several years, we've seen us come back to a time where we're actually doing more breast conserving surgery than we are mastectomy. So while if you'd asked me 10 years ago, I would have told you that we were only doing about 40% of our breast cancer surgeries as breast conserving, we're actually closer to 60% or maybe 70% in some centers. When we look at our own Massey Cancer Center numbers, we've actually remained quite steady over the years. I think it demonstrates that we're counseling patients and telling them what their options are and guiding them to the right choice for them.
Thank you. The next question is for Dr. Hackney. If I have a strong family history of cancer, what is my chance of getting another cancer?
So I'm going to take it that there is a concern about family history, whether it's breast cancer or other cancers. I think this is an ideal time that it makes sense to talk with a genetic counselor to see if you have a gene that's in your family that might make you higher at risk for getting a type of cancer. We do see some cancers linked together. Breast and ovarian are linked with the BRCA gene. Pancreatic is also linked with that, and prostate is linked with that. There's another group of genetic abnormality called the Lynch syndrome, and we see colon cancer and breast cancer in families there. So if there is a cancer family history, I think talking with genetic counselors and finding out, is there something you could do to test for a gene? And then you use that information to determine the best screening. Now, the one thing to think about is there are only so many cancers we can really screen and detect early. Mammography being one of the big ones for breast cancer and one of the best ones for making a difference in mortality. Pap smears, colonoscopies for colon cancer, prostate cancer screening. Those are really our major cancer screening tools that we have out there. And so it's important that people use the tools that we have, whether or not you have that family history, to try to detect cancer earlier, because we know if we detect it earlier, treating it's much easier.
Thank you. Our next question is going to be for Dr. Arthur. What are the possible long-term effects of radiation?
Well, I think a lot of it depends on a couple of things. It depends on where we're treating, how much volume of the tissue that we're treating, what normal tissues may be in the path of the beam, depending on what we're trying to treat, and of course, age of the patient. So when you talk about early stage breast cancer and either treating the whole breast or treating part of the breast, if the radiation is delivered with contemporary techniques, heart and lung are not at risk, regardless of whether treating the right side or the left side. And that's a common misunderstanding by people that have not been able to keep up with the technology and radiation. So the effects of radiation for early stage are really going to be on the breast tissue, talking about the skin, talking about the breast tissue itself. And although they're minimal, we can see some coloration changes in the skin. It may stay hyperpigmented. On a rare case, we may see telangiectasia, these little red streaks that come up on the skin after years. And we may get some thickening of the breast tissue. But for the most part, those are relatively minimal. I would say less than 10% of people have anything that's bothersome or irritating from radiation change, other than perhaps some skin discoloration that sometimes we can't avoid. But if you start talking about local regional treatment, where we have to encompass treatment that's covering lymph node areas as well as cannot avoid some of the lung, then we start talking about there's a percentage risk of lymphedema that we do everything we can avoid, and although the risk is low, it's possible. That's a swelling of the arm. Lung effects, pretty low. It's very rare that we have any permanent damage to the lung from radiation treatment for breast cancer, although occasionally we may get somebody that has a temporary cough or shortness of breath. Heart, you have to look at the old data and old techniques to really see any long-term effects on the heart from radiation because of the technology we've used today. So we do a pretty good job in the area of breast cancer of avoiding long-term side effects other than those soft tissue breast and skin changes that I talked about.
Thank you, Dr. Arthur. Our next question is for Dr. Lauren Nigro. What kinds of changes to the breast can I expect over time? And then the second part is, how does aging affect the reconstructed breast?
All right. Well, unfortunately, none of us can fight gravity. And reconstruction is certainly a process. So the breast is no exception. We lose elasticity of the skin as you get older. You experience increased drooping, or what we call ptosis of the breast, and that includes of the reconstructed breast. As you get older, if you did opt for the implant route, you will notice the need that your plastic surgeon will bring up with you the need to exchange your implants with time, typically every decade or so. If you did opt for your own tissue, you will notice that skin and tissue will start to droop in the same way that your natural breast otherwise would as you get older. And then, the one component to follow Dr. Arthur's comments about radiation is that, the radiated side might react differently than otherwise non-radiated skin in terms of how it behaves as you age. That side might not droop as less. It might not have as much of a change due to gravity as you would otherwise notice. But those are the main effects that we see. And there are techniques that we have that can help combat those, including lifting techniques for the breast that work very well.
Right, thank you. I really want to thank all of you all for joining us. Tonight's panelists, Dr. Hackney, Dr. Shaw, Dr. McGuire, Dr. Arthur, and Dr. Nigro. I want to thank the audience for joining us and for participating in this VCU Health seminar on breast health. To learn more about the awesome physicians at Massey Cancer Center that you have joined with us tonight, visit vcuhealth.org. And to stay connected and up to date on the advances in cancer research at Massey, follow at VCU Massey Cancer Center or visit www.masseycancercenter.org. Lastly, to schedule an appointment with Massey's breast team, please call 877-4MASSEY. And then the numbers are down there, 877-462-7739. Once again, thank you, Dr. Shaw, Dr. McGuire, Dr. Hackney, Dr. Arthur, and Dr. Nigro, and to all of you who joined today. Have a great night.
Our pleasure.
Thank you.
Thank you.